Good afternoon, and thank you for joining us for today's webinar, COVID-19, the current status of testing, treatments, and vaccines. For over 30 years, the National Organization for Rare Disorders has focused on the health and well-being of people living with rare diseases and their loved ones. We want you to know that during the COVID-19 pandemic, our commitment to serving you is stronger than ever. My name is Katie Kowalski. I work in the Education Department at NORD, and it's my pleasure to be your host for today's webinar. This webinar is part of NORD's COVID-19 education series, which consists of webinars, information guides, videos, and podcasts. This series is being brought to you with support from Biogen, Horizon Therapeutics, Sanofi Genzyme, and Strongbridge Biopharma. NORD's been busy creating COVID-19 related resources. Please visit our COVID-19 Resource Center for a listing of events and information. And now I'd like to introduce today's speaker. Dr. Rishi Desai is a pediatric infectious disease physician with a public health background who currently serves as the Chief Medical Officer at Osmosis. After completing his medical training, he worked at medical centers including Boston Children's Hospital, Boston Medical Center, Children's Hospital Los Angeles, and Stanford University. He earned his MPH in epidemiology at UCLA and subsequently spent 2 years at the Centers for Disease Control and Prevention as an epidemic intelligence service officer investigating disease outbreaks before beginning his work in online medical education. And I'll add that NORD proudly collaborates with Osmosis to produce educational videos about rare diseases. So we're thrilled to have you here today, Dr. Desai, and with that, I'll turn it over to you.
Thank you for inviting me. This is obviously a huge pleasure for me to do this, and your community is fantastic. So please send in questions. I'm reading the ones that are already there. They're excellent, so just drop in more, and I'll try to address them after we go through this. We are going to go through a lot, so if there's anything that I say that's confusing, please flag that as well. The idea today is to talk about current status of testing, treatments, and vaccines. We'll start with testing. There are, at the moment, I dropped in data from end of April, but looking today, daily we're doing about 230 to 250,000 tests. So when I say that, what I'm really referring to are the RT-PCR tests, where they put a swab in your nose and you look for viral RNA. That is roughly a quarter of what I think we need to get to and what various estimates have been put forth in terms of the level of testing we need in this country. So we're still very, very, very far from where we need to go. But 250,000 tests or so per day, just to put that in perspective, we did a total of 1 million tests in the months of January, February, and March. So really going from that level, 1 million over 3 months, to doing 250,000 in a day is obviously a big step forward. There are kind of 3 phases. That first phase is the early phase, January, February, March, where we were doing almost no testing because there was only one test available for a large majority of that time. That was the CDC test, which was largely faulty. And as a result, public health labs couldn't do more testing. That was what stymied them. To phase 2, which is kind of where we are now, where we're doing 150 to 250,000 in the month of April, and trying to push beyond that in May, but really haven't made a lot of headway there. And phase 3 is where we need to go, which is, again, like around, let's say, 1 million per day. And of course, this depends on which community you're living in, because if you're in some communities where testing is more available, then good for you, because that means that your community is more likely to have a strong public health infrastructure in place to figure out where the cases are, so that if there is an outbreak, they can quickly test the people that are involved and isolate those people and quarantine those folks. But if you don't have a lot of testing available in your community, then that means, and I apologize for the dog in the background, then that means that basically your community is not going to be able to effectively handle the number of cases that are coming up. Now, on the left of your screen, you see an image for block testing. And this is kind of an interesting idea that is being used in a couple of countries. Germany and Israel are using this. The CDC Deputy Director Ann Schuck, I spoke with her, and they're actively trying to do block testing in the U.S. And in brief, the way this works, it's a really cool idea. It's that, let's say you have 10 people. Instead of swabbing all 10 of them and then doing an individual RT-PCR on each of them, instead what you do is you basically take 10 swabs, so you still swab everybody, but you do one test. You put all 10 swabs in one pool of liquid, and then you see if that pool turns negative or positive. If it's negative, you presume that all 10 people are negative for RT-PCR, and you've saved yourself the trouble of doing 9 other tests. If it's positive, then you go back and then you might subblock. You might do 5 and 5 to kind of narrow down who's the individual person that actually ended up being positive. So that's what the image is showing. The idea here is that you can rapidly scale up testing capacity without any kind of extra reagent or extra RT-PCR machines or any of that kind of stuff. It's a technology that allows any lab across America to scale up quickly. So that's the idea behind block testing, and it's something that you'll likely hear more of as we start doing more routine surveillance in communities where there's a pre-test probability that's quite low, meaning that we don't suspect that people have positives, and you think most people are going to be negative. Block testing works really well in that setting to conserve resources. So now, in terms of treatments, you've heard tons of treatments out there, and I see questions specifically about plasma therapy and IVIG, which I'll address. But there's other stuff too, like vitamin D and medications like remdesivir and hydroxychloroquine and azithromycin. So let's go through each of these very briefly. Plasma therapy, for those that haven't heard of it, it's basically taking antibody from person A, who may have recovered from COVID-19, and then injecting that antibody into person B. And that antibody presumably should be at a certain level, so we would call that a titer. And if it's at that high level, then it has a benefit for person B, who's maybe suffering from COVID-19 actively and trying to get through the worst of it. Now, this is a great way to kind of bridge someone over. We certainly use this with other viruses, and it's effective, for measles and other viral illnesses like that. We've done it, and it's been used in COVID-19. Increasingly, many hospitals have reported benefit, but the challenge is that we haven't really seen randomized clinical trials around this. So you know that people are likely benefiting, but these are people that are also on antiviral therapy, also getting steroids. So it's hard to say how much benefit they're getting and how much of it is specifically tied back to the passive immunity, to the antibody. So that's the context of it. And a lot of people are wondering, what if you get IVIG? What if you're on a treatment protocol where you get IVIG on a regular basis? Does that mess up your ability to show that you have antibodies against COVID-19? And the clear answer is we don't know. I would presume the answer is yes, based on other viruses and other diseases where that answer is yes. But with COVID-19, we don't really know. And one of the things that has been proposed is, what if we have an immune threshold where we say only if your antibody level is a certain level, then and only then do we believe that you're truly immune to COVID-19. And one proposed level was 320. So meaning a titer of 1 to 320 is needed to really believe someone has a strong immune response. So that's just one example of something that's been proposed in the scientific community for when you should believe whether someone's actually immune or not. Next one, vitamin D. We know that a lot of folks are vitamin D deplete. There's studies, there's a meta-analysis out there that shows that vitamin D supplements and getting someone to a good level is actually going to help prevent respiratory infections. The Society of Endocrinology has actually gone out and said that they believe that levels should be above 75 nanomoles per liter. And many people in the U.S. and around the world are below that level. So ideally, getting your vitamin D level above that level, again, 75 nanomoles per liter, can help with respiratory infections such as COVID-19, in addition to other types of things that folks may be suffering from, like good bone health and other things that vitamin D can help with. So certainly vitamin D has been shown to be effective in that setting. Now with hydroxychloroquine and azithromycin, I'll touch on this very lightly. This is not something that's actively in the news because increasingly the studies show that it's not that effective or maybe not effective at all. And in fact, there is toxicity with those medications, specifically cardiac or heart toxicity, that has made some patients not even good candidates for getting those medications. So that's not a combination that is being actively explored. The final one, or let me rephrase, is in randomized clinical trials, but is not one that is talked about a lot these days. The final one, remdesivir, in contrast, is talked about a lot. There are data points now, there are studies that have been shown that show that it is effective in some settings. But again, the data that I've looked at with remdesivir show that it helps in patients that are on, other, let's say, medications. They may have gotten better with time anyway. It's hard to say. There was one randomized clinical trial out of China published in The Lancet that actually showed remdesivir didn't really make much of a difference compared to placebo. So it's hard to really know what to make of these drugs. I think as more data comes out, we'll get a better sense. And truth be told, I think what we'll find is that it's likely going to be a combination of therapies, maybe a combination of antivirals plus maybe steroids plus potentially plasma therapy as well. So that's likely what's going to happen in the coming weeks and months. All right, moving our attention to other treatments, specifically ventilators. And one of the things that we've heard about is the idea of splitting ventilators. What that means is essentially attaching a little piece, a little Y-shaped piece, to a ventilator and then allowing one vent to be used for 2 patients or maybe even 4 patients. And this has been done now actually both with mechanical lungs, so just kind of showing it with simulators, but also Yale did a study where they did it with real patients. And this is a kicker, they did it with 2 patients that had different types of disease processes. One person was very differently sick than the other, and the same vent was able to monitor and treat these two patients. Now, fortunately, we haven't seen the need for a lot of vent splitting. A lot of societies have come out against splitting vents because the monitoring can be very difficult and managing 2 different types of physiologies can be difficult. But in a pinch, this is probably something that will be necessary if we end up in a scenario where there are very limited resources, such as potentially in rural settings, maybe even internationally, where other countries might be in this bind where they don't have enough ventilators. But in those settings, you might see that. But again, at the moment, that's not really being seen on the ground anywhere. Next, prone positioning on ventilators. That's literally where you're sleeping on your stomach instead of on your back. That's what prone refers to. And prone ventilation for 12 to 16 hours seems to help. And the reason being that the heart is, by gravity, kind of pushing down on the less of the lung tissue. So that frees up more of the lung tissue to kind of open up and breathe more comfortably. And of course, that's a big part of what these patients need. The last one, managing L versus H-type patients. This is kind of interesting, and I think specifically relevant to this community of rare disorders, because we're learning new things about COVID-19 every day. We didn't know and didn't think about the fact that maybe the main issue with these patients may not be the lungs. And in fact, this paper puts forth the idea that maybe these patients are actually suffering from a perfusion problem, a blood vessel problem, and that maybe at its core, COVID-19 disease does affect the lungs, but might also be causing disease of the blood vessels themselves. And in fact, we know now that you see strokes in younger people, that's probably the same mechanism. So COVID-19 is probably affecting 2 different parts of the body, the blood vessels and separately the lungs. And this paper talks about L versus H-type patients as to whether the lungs are more affected or the blood vessels are more affected. So again, the reason I think it's relevant is because it's an ongoing process in terms of understanding the disease mechanism. And once you understand the disease mechanism, you can interact and treat it more effectively. With this case, if it's a blood vessel issue, you might try something like low molecular weight heparin. And that's something that they actually have shown seems to be helpful in some patient populations with COVID-19. So let's just jump over to vaccines now. There are over 100 vaccine candidates, and a handful of them are in phase 1 or 2 trials. Just to back up just a bit, phase 1 trials are safety, just to make sure the vaccine is safe. Phase 2 trials are around immunogenicity, meaning do you get an immune response if you get the vaccine? And what you see on the right here, actually on the left, are the kind of listing out of the various vaccines that are there in phase 1 or 2. There are some additional ones as well. And then on the right, what you see is data on how long your IgG levels stay high after you've received a vaccine. So that's actually looking not at COVID-19, but other coronaviruses. And what you notice is that it's nice and high, it kind of rises for the first few months. It stays really high, and then after kind of 2 to 3 years, it starts to fall. And the question is that does that mean that you need vaccine maybe every 3 years? Are we talking about an ongoing vaccine series if the immune system is starting to kind of trail off after a few years? The quick answer is we don't know, but this is not unexpected. Oftentimes, with many vaccines, your titers start to trail off. But that doesn't mean you're not immune anymore. What that more often means is that your B cells have a memory of the right antibody to make. And as long as you have those memory B cells around, you'll be okay. Once you see that virus again, you can mount a good immune response and that you'll be fine, even though the amount of antibody has fallen. So that covers some of the background. And vaccines, just to put it very bluntly, is going to be likely out in 2021. We don't know, of course, which quarter, and there's a lot of guessing back and forth about that. but I think almost everybody agrees 2021 is what we're looking for. So the strategy kind of in the months ahead, really, to that point, is how do we keep people as safe as possible until the vaccine is around? There are these projections that you may have come across around what we should expect. And what you notice is that essentially there's a mountain or a hill here of cases, and that we're kind of on the downturn of that hill. Now, here's a hot off-the-press update for you. These projections are based on continued social isolation or social distancing. And as many of you likely know, at the beginning of May, many states began to relax those social distancing orders, those stay-at-home orders. And so, in fact, these models are now changing. And there's now kind of an upward trend again towards potentially a second wave. And that's going to depend which state you're in. So, for example, let's say you're in the state of Washington. You can see that the number of cases in Washington, which really got hit by COVID-19 earliest in the 50 states, is that we're very much on the downturn. So for Washington, and they also have a very strong public health system compared to many other states in the union, they're likely in a much better scenario right now because they have strong public health infrastructure, really good testing levels by comparison, and they have fewer cases. So even if they relax social distancing, they're likely going to be fine with that. But by comparison, you look at Wyoming, and Wyoming is really hasn't even seen the worst of it yet. And so in that state, if they were to start de-isolating, it's going to be a tragedy. So that's just a quick comparison of what you're going to see state by state. I think in general, most states are relaxing way too early, and we aren't at the public health level of detection with testing where we need to be able to take care of all the cases that are going to be in the community. And as a result, you might start seeing spread happening and a resurgence, especially in certain areas like among high-risk populations, specifically in groups where those high-risk people congregate. So I'm thinking of skilled nursing facilities as an example. So with that, why don't we just jump into questions and answers, and I'll start going through the ones that have come in.
Yeah, sounds great, Dr. Desai. Thanks for sharing all that timely and important information. So indeed, let's jump right in. So first, could you comment on the relationship between the availability of testing for COVID-19 and the lifting of social distancing? You were, talking about that right as we were closing, but if you could just comment further.
Yeah, let me spell that out really, really clearly. So there are two numbers. The first number is how many tests can be done in a metro area. So I'm just going to take my home metro area of Oakland. So how many tests can be done, RT-PCR tests and serology tests in this area? And there's a number there. Maybe it's 50,000 a day or, whatever the number is. So that's one number, and the public health system knows that number. They can identify which labs can do it, how fast they can do it, and also how quick they can do it. Because again, what if you did it and then you didn't get the results for 5 days? Well, now a person's been infectious for those days because that's when their peak infectivity was. Presumably they came in for a test because they were having symptoms and therefore were contagious. And if for 5 days they didn't get a response, then you really missed the boat. So I don't want us to think that just because a test is done, that means that we essentially can count that test. It only counts if it's done and it's acted on appropriately quickly. So that's the first thing, is how many tests are you doing, how quick are you getting those tests turned around so that people can act on it before they go and spread it. And then the other piece of that is how much contact tracing is available in your area. Do you have people that are waiting in the public health department to make phone calls? Let's say I come back with a positive test. Are they going to call my friends, my family, and identify who else might have been around me for the last 2 weeks? And if not, then those people might be contagious and might spread it. So we need to have people on the phones ready to do contact tracing, ready to help implement quarantine. So that's the first side. And I said one number, it's the number of tests with all those caveats. The second number is how many cases are out there. And the only tool we have at the moment to try to mitigate that is social isolation or social distancing. And so a hard number is you can look at how many deaths are there in all the hospitals in the Bay Area. And is that death count going up, right? So that's a very hard number because it's very hard to ignore or not catch a dead body. So you would notice that. You would notice if someone died. You would know that they likely died of COVID-19. And the next proxy would be hospital visits or hospitalizations. there again, you're likely to know how many people are coming in with a syndrome of COVID-19 and with testing that would confirm it. So we can look at that and we can say, well, based on the fact that we've got this many hospitalizations and this many deaths, we can back calculate how many people we think there are in the community. Maybe you multiply it by a number. Maybe that number is 100 or maybe 500. You can multiply it by some number and say, we think our best estimate is that our community has X number of people walking around today with COVID-19. And so then you just compare those two numbers. What's our ability to catch those asymptomatic people that are walking around versus what's our capacity to, or versus what's the number of people that are out there that we need to catch. And if you can't catch the number of people that are likely out there, then this is going to start exploding, getting out of hand. Does that make sense?
That makes sense, and that's very helpful. Thank you. And having said that, can you talk about the role of antibody testing and what that can tell us?
Yeah, absolutely. So back in February, I'm just going to go back just a couple of months, we had really one, and at the end of the month, two tests that were FDA approved for RT-PCR. One was the CDC one, and that one ended up being a bit of a flop. It wasn't very effective. It was faulty. And the other one was on the last day of February, New York State Department of Public Health were granted an FDA emergency use authorization for their RT-PCR test. Bottom line, we didn't have a lot of tests that were FDA approved, and as a result, not a lot of testing was being done. Fast forward to May, and now you're asking about serology, there are not that many FDA-approved serologic tests available out there. There are a handful, and they're quickly getting approved, but that approval process still is lagging behind how many tests are available. So many tests out there are not FDA approved. I'll just put that out there first. Second of all, a lot of these tests are not tested by third parties. So they'll make claims. They'll say, 90% of the time we'll catch the disease, we're 90% sensitive. 90% of the time, we identify correctly that you're negative. That's the specificity. But it's not been vetted by a third party. And so what we need to do rapidly is start testing them against each other. Let's take a standard set of known positives and known negatives and say, let's just test all of the different serologic tests that are out there against this batch. And some of that is starting to happen, not by the government, but by private groups and academic institutions. So there are some papers that have been published, and that's the problem, is that as serology starts to kind of ramp up, we're going to get a lot of people that are going to say, okay, great, now I have a positive, do I believe it? Or I have a negative, do I believe it? And especially in people that have had IVIG and, and have plasma therapy for other reasons, it becomes really, really tricky to know when to believe these tests and when not to.
Yeah. So another question then, and you hear this a lot, if a person has already had COVID-19, can they be reinfected and can they get it again?
Great question. The quick answer for this one is they're immune. So if you really got COVID-19 and you really have a working immune system, then you're very unlikely to get it again, even if you got a different strain, which I know is a commonly asked question as well, because there is a protein on the surface of the virus called spike. It's very easy to remember because of the name, and that spike protein is pretty stable across different viruses, different strains. So if you have an immune response to one strain, you're likely to not get COVID-19 again. And the cases where you do see reinfection, I know I've seen the headlines of South Koreans and Chinese citizens getting reinfected with COVID-19. What's happening in those situations is something quite different. It's the test is messing up. So let me give you a couple quick scenarios. You get sick with COVID-19, you're positive. You go home, the test says you're negative, but you're actually not. You go home, you start feeling worse, you go back to the hospital, and you test positive again. So you think to yourself, I got reinfected. The truth is you never got over the infection in the first place. That was a false negative test. Another scenario, you have COVID-19, you go home, and then you get the flu virus, and you get tested, and it says that you have COVID-19. In that case, it's a false positive. Actually, you don't have COVID-19. It was a false positive. You actually have flu the second time around. So, or maybe you have coronavirus, meaning another coronavirus strain. Because keep in mind, we had coronavirus strains circulating other than SARS-CoV-2, which is the strain that causes COVID-19. And so maybe you have another coronavirus strain, and that's triggering the test to think you have COVID-19 again. So that's what's likely happening, is that it's a testing issue and not that your immune system simply isn't mounting a response.
Okay, so that helps explain some of why people are seeing these positive tests, then the person tests negative, and then they're testing positive again. Now, you mentioned the flu, and a question about the flu, will getting the flu vaccine be recommended this year? Should people, have their flu vaccine at the normal time in the United States this year?
They should. That's another quick answer. They should definitely get flu vaccine if they're eligible for it. The flu vaccine, and this past season has been kind of a rough one in terms of having a lot of flu cases. And as you might imagine, getting the flu, this is the worst time to get the flu because A, you get sick. Nobody wants to get sick. B, you create a lot of anxiety around whether it's actually flu versus COVID-19. So that's obviously another whole barrel of anxiety you don't need. Another thing is that actually getting the flu weakens your lungs. And the last thing you need right now is to have a weak set of lungs walking into an area, and the U.S. is, the hottest area in the world right now for COVID-19. So you don't really want that right now when there's so much disease circulating. So for all those reasons, I would recommend if you're eligible to get flu vaccine to go out and get it.
Right. So now a question about people with rare conditions. Since they are, at high risk, do you think they should be prioritized for COVID testing?
It's a good question. When it comes down to prioritizing COVID testing, I think the underlying question is how do you distribute a scarce resource most equitably, right? And I would argue that right now, for our entire country and frankly our world, we need to not let this resource be scarce. We need to focus our attention on making sure everybody that needs testing can get testing, and not just this community or that community or anything like that. Because if your neighbor can't get testing, you're not safe either. And so I think really if we want our economy to eventually open up and for all of us to get back to normal, we need to have more testing available. And what that means is things like get the FDA to approve more, to authorize more serologic testing, get labs to be able to build up their capacity by having basically contracts with local hospitals in place, and frankly get the government to help make that occur, not just on a state level, but on a federal level.
Thank you. So then with, you mentioned the FDA and a question about vaccine rush to produce a vaccine. Do you think that safety could be compromised, and how can we be sure that a quick fix isn't going to create problems in the future?
It's a great question, and one of the longest steps of vaccine production is phase 3, which is the efficacy trial, and that's where you're trying to see whether people with vaccine have lower rates of infection versus people that don't have vaccine. And one idea to try to speed up that phase is human challenge trials, where you literally give the virus to a person, which is, on the face of it, you think to yourself, wait a second, that sounds so unethical to give people the virus. And yet this has been done before. The WHO has a whole position paper on it. I think that safety is going to be paramount. And these phase 1 and phase 2 trials that I talked about, those are the ones that are really, really taking a hard look at safety. It's the phase 3 trial, which is the efficacy trial, that might be shortened just to see if it works in the first place. So I don't think that there's going to be any shortcuts around safety at all, but I think that the efficacy will likely get shortcutted, at least in some settings. Great.
So we've reached our time, but if it's okay, we'll move forward with a few more questions. So, Rishi, are there any particular concerns that immune-suppressed people should have about possible vaccines and treatments? Like, do you think they would be at greater risk from vaccines or treatments since they've got suppressed immune systems?
Yeah, I do. I think that there's going to be a lot of research that needs to go into understanding how, and of course, when you say immune suppressed, it's not one category, right? Like, so some people might have problems with B cells, T cells, both cell lines, maybe natural killer cells. And in really understanding what arm of your immune system is impaired is going to affect how you're able to mount a response to COVID-19. and whether you're a good candidate for medications as well as vaccine. So I think we'll have to take a good hard look at that. But definitely this is not something to be ignored. And in general, folks with immune suppression do have trouble, again, depending on the arm of immune suppression, but clearing viruses. That's a very known thing.
Thank you. So I know, Dr. Desai, you're not sitting there with a crystal ball in your hands probably, and this is a question I know everybody's asking, but it's come in from one of our participants, and it says, how long do you think it will be before life gets back to normal? And a second question, actually, what do you think are the most precautions to follow in the post-COVID world?
That's a great question. It's a question that I get from my own family. I think that there will be a difference. I don't know where the participant that just asked this question comes from, but I suspect they might come from a different part of the country than me. So I'm living in Northern California. Let's say that person that just asked the question comes from Georgia. You know, the number of cases in Georgia, the public health infrastructure in Georgia is different than Northern California. And as a result, we're going to see potentially more cases or more disease in those settings. And some states might have to basically dial it back down again and say, okay, you know what, we need to isolate again because it just got out of hand and we don't have the public health infrastructure in place. We're not able to do the testing at the capacity that we need right now. And the only way to prevent our hospitals locally from overflowing is to have us shut things down again. There is a very, very real risk of that happening in numerous parts of this country. So that's the first thing, is that this is not going to be one answer across the country. It's going to be very much a scatterboard of what happens depending on how things in your area are being handled. The second thing is that there are elements of this that likely will get much better and will look quite different a year from now. So once, let's say, a vaccine is available and you know, that's going to protect, let's say, the majority of people, then we really are asking different types of questions from now, because at that point, maybe some things culturally are normalized. Maybe now online education is a bigger thing, or maybe Zoom meetings for work are more normalized. Maybe people just naturally expect everybody else to wear a face mask if you're coughing in a grocery store, and you'd be scowled at if you didn't. You know, there are probably things that are long-standing that are going to change. Other things are probably going to be quite similar. You know, at some point, we would expect that schools and daycares and things like that would reopen. Probably the last thing to reopen would be recreational things like, you know, theater and movies and things like that. So I think that it's going to be phased. It's going to be regional. The thing that I worry the most about, to be perfectly honest, is what this says about digital surveillance. You know, we already know that Google and Apple are collaborating on creating digital surveillance tools for public health tracking. So there's going to be a lot of questions about privacy and who gets that data and how long is that data, you know, kept around for in terms of where we're allowed to be and things like that. So I think there are going to be lots of technological questions like that at the moment people probably aren't even thinking about, because frankly they just want to have dinner with their family again.
Yeah, no, it's just like we thought after 9/11, you know, the world's not going to be the same. You know, same thing here. There's going to be certain things that don't go back to the way they were.
Exactly.
So, final question, something about the future. As we look ahead to the possibility of future pandemics, you know, what lessons, what valuable lessons do you think we can take into the future given our experience with COVID-19?
So one example I like to use here is, you know, there's a country we're holding on a pedestal at the moment, and that's South Korea. South Korea has a sixth of our population, and they dealt with this really effectively and really didn't see the number of hospitalizations or deaths near, you know, what we've had to deal with. So how is it that they were so effective? Well, if you rewind the clock, they were hit by MERS, and they saw SARS too. And so with those experiences behind them, they knew that when you have a respiratory person-to-person spread of a coronavirus, that is not to be dealt with lightly. And they aggressively handled it. Coronaviruses have now hit us 3 times, SARS, MERS, and COVID-19, in the last 20 years. Average that out, that means that in 7 years or so, we should expect another one, right? I expect that there will be another coronavirus. We're probably going to, as a human species, going to continue to deal with them as long as humans and bats coexist, which is kind of the reservoir for these viruses. So we probably, I hope, will learn a lot of lessons from this going into the next pandemic, whether it's from a coronavirus or H1N1 flu or whatever it is. I think we realize how it can cripple our economy. And if we don't act fast with testing and isolation, it can explode on us just like this one did. So my hope is that we'll start building up better public health infrastructure to avoid this calamity.
Great. Well, thank you, Dr. Desai, for sharing all of this really useful information. Thank you for being with us today. To all of our listeners, you're going to receive a short survey, and we ask you to please complete it because it will help us to develop future webinars. We want to send our thanks again to Sanofi Genzyme, Strongbridge Biopharma, Horizon Therapeutics, and Biogen for supporting this event. And we thank all of you for joining us. Please enjoy the rest of your day.